hear from Dr. Mohan Rajan. Would you share your screen, doctor? Yes.
Able to see my screen?
Yes, yes.
Sorry. Okay. Thank you very much, Chitra, for this wonderful opportunity. Premium IOLs, I'm doing against SICS. The disclaimer is there. It's only for the sake of the debate. My guru, my mentor, my role model is also an alumnus of Shankar Netralia. I know he's from a big institute like All India Institute. I'm asking all the panelists, all the top panelists Chitra introduced, how many of the panelists are doing SICS for premium IOLs? The answer is none. So why would you want to have a debate for this and waste your time and my time as well? Change is the only constant. Yesterday, today, and tomorrow. Today it is Stalin and tomorrow I can become the chief minister as well. Are you still using the old bulky phones? Or how many of you are using smartphones today? Because of smartphones only we are on this technology today. I have a lot of regard for Ravindra. Excellent speaker, surgeon, clinician, academician. He can stand upside down and do the surgery. Teacher, multi-talented. But unfortunately, you know, his name itself says he's a manual small incision Ravindra. So that is the reason why he cannot think beyond manual small incision for any of the premium IOLs as well. Friends, we are not talking about the comparison of MICS and SICS. It is like comparing Rahul Gandhi and Modi, Kamal Hassan and Rajinikanth and Sachin and Dhoni. They are different. The sun is setting on the old mindset. We have a patient who's like a luxury consumer, a plastic surgery patient. He wants uncorrected vision, distance. Himanshu was telling distance, intermediate, near as well. Do you use this old technology? 1 GB, as big as the size of the room. Newer technology is coming. These are the 4 mantras as far as refractive surgery is concerned. Address the astigmatism, decrease the complications, choose the best quality visual IOLs, exceed the patient expectations. Premium IOLs definition, MF, MF toric, EDOF, espheric, accommodating, so many things are there. Now, I would say that every IOL is a premium IOL because you need to give. The golden triangle is premium IOLs. Ravindra is doing a lot of them. He's a premium surgeon. He's a #1 surgeon in Bangalore, #1 surgeon in Karnataka, #1 surgeon in South India, I would say. I have a lot of regard for him. But is he doing the premium surgery? That is what is the question today. He is not doing the premium surgery for premium IOL because you have to consistently hit the bullseye. You need to consistently hit. There's no margin for error in a premium IOL, in a multifocal or a multifocal toric. Surgically induced astigmatism, huge problem. If you say that against the rule, I will put a temporal incision or with the rule, I'll put a superior incision, superior temporal. You don't have any control. You put a 4 or 5 millimeter. You do not know how the wound is going to heal. Rex's size, effective lens position, complications. You can see how this size of the incision in SICS, 7 millimeter. You can see the size of the incision in MICS, 1.8 millimeter if I'm using a Stellaris, or a 2.2 millimeter if I'm using an Alcon machine or whatever it is. It is 2.2. There's no induced astigmatism at all. Small incision, faster recovery, no SIA, less inflammation, less CME, better control. Rex's ideal size, ELP, all these are under control. Fibrin reaction, complications like cystoid macular edema. And if you do a temporal incision as large as 4 and 5 and you don't suture it, increase in of endophthalmitis also because the whole wound is exposed to the atmosphere. Commonest cause of postoperative visual recovery. Site of scleral incision, the size of the scleral incision, surgically induced astigmatism, larger the incision, more the astigmatism. I don't have to tell all these learned colleagues, larger the incision, the more the astigmatism. Everybody knows about it. That's why we are going for minimal invasive cardiac surgery, vitreous surgery, cardiac surgery, prostate, robotic surgery. Smaller incision, the faster the recovery, the better the results. Minimal invasive surgeries are definitely better. Multifocal IOLs, I've just done a study, 2,100 eyes. You see my wounds. Wounds are pristine. It's very good. 1.8, 2.2 millimeter. Absolutely no stromal hydration or anything. no corneal burn, nothing, even a cataract of a very dense cataract. 96% of my patients drive without glasses, see the computer 6/6 N6 without any problem, no surgically induced astigmatism. If I have an incision of about 2.2, institutes like L.V. Prasad, Aravind, which has got the largest study of SICS, RP Center, all these things, I can quote many thousands of papers of literature. One case, there are 3 or 4 surgeons who feed me regularly in Chennai.
So 1 minute remaining.
Surgeons like multifocal IOL, patient not happy, residual astigmatism. You can see the IOL is there. This is a large lens. You can see he put a 6.5 millimeter. Obviously, you have to put a very big rexis to dare the patient. There is a forward movement of the lens and there is a myopic shift. So all these problems can occur. Now I'm doing femto catalyst because my results are even better. I'm able to hit the lens at the bullseye consistently in premium IOLs. Preferred practice patterns, evidence-based medicine, consistency, competence, and control. The 3 C's as well as MICS in premium IOLs is concerned. My dear MSR, I know you've got a Stellaris phaco machine. Okay, and you're doing this regularly. So from the horse's mouth, MICS is the best for the premium IOLs. And SICS premium IOLs, you know where it belongs. Thank you very much for the wonderful opportunity, Chitra, AIOS.
Thank you, Mohan. We couldn't have expected anything less from you. But having seen Ravindra's surgeries and the accuracy which he has in SICS, and of course, I would have a question for Ragini too, because she also does a high volume SICS surgery. My first question to you directly, Dr. Ravindra, is that how do you control your centroid SIA? How do you do that? Because there are certain densities of cataract where you cannot stick to your phaco fracture and small sized incision. If that is going to be variable and even your wound can be put on a stretch if you stick to a small incision, how do you deal with that moment?
You're asking for Ragini or myself?
Asking you, Dr. Ravindra.
Okay, fine. It's very easy. It's a question of mismatch or matching the size of the cataract. You're going to remove it anyway, throw it out. It doesn't matter how much you're going to distort the cataract, but your care is towards the respect to endothelium. That's number one, which stands whether you're doing SICS or phacoemulsification. Second is stretching the wound. It's like I make a larger tunnel so that I don't stretch the tunnel, so that my astigmatism is least. I can have a 0 astigmatism with my 6 millimeter incision, provided I don't stretch it. Phacoemulsification is a lot of not only stretching. You make a 2 millimeter incision and you make it 3 millimeter by stretch. It's 1.5 times stretch when compared to the diameter of a probe that you're going to insert, and also the heat involved in the tunnel, which everybody knows that there is a heat involved. Everything heals there. But what is there is leave behind a pristine tunnel and leave behind a pristine endothelium, and any surgery they adopt will give excellent results. SIA is not an issue at all in SICS.
You mean to say you vary your SIA in different sizes of incisions?
Yes, not only different size, where you start the incision, I can start in anterior sclera, I can start in posterior limbus, I can start in mid limbus, I can start in the anterior limbus and the cornea. Based upon it, we have a formula, and if the width is identical, 5 millimeters, then you can titrate the amount of astigmatism. Like I can create 1.25 plus minus 0.25 by designing an tunnel. That's a possibility. And the other biggest advantage in SICS is it's a very low pressure. The pressure is 0 to 20. It's never more than 20. So it's very physiological to the eye. The fluidics is very, very slow and low. The entire amount of fluid that I'm going to use to do a cataract surgery is about 25-30 ml max. So the amount of churning you have inside the eye is least, and the pressure is low and the flow is very low. So these are the controls we have on the surgery, which is in the tip of your fingers instead of your foot controls, machine controls, which runs in huge speeds.
Dr. Susan, do you do occasional SICS? Don't do?
Yes, ma'am. Of course, I do occasional SICS.
But then I would also ask you this question, because you're the expert panel here. This rexis size, Rex's size cannot be consistent, and we know Rex's size is so critical for effective lens position and all that. So Rex's size would increase if the density of the cataract would increase. So how could you promise emmetropia, and anything less than emmetropia is not acceptable for a premium IOL? What are your thoughts on that?
Well, I'll be frank, I do not have the experience that Ravindra sir has. So I do not do premium IOLs in SICS, but I definitely do have very clear indications for SICS as well in my practice. It's not that I do not do SICS. There are many situations where I prefer an SICS over a phacoemulsification. But I guess Ravindra sir would do phaco-fractures and all those other things to be able to get the cataract out, and I'm sure Ragini can also do that. I really believe that SIC is a beautiful technique which should be mastered by everyone. You cannot just stick to cataract and phaco all the time. You need to definitely know SICS. And one thing that I do sometimes, I haven't been able to master it again to the point of 0.25 millimeter plus minus astigmatism, but I do use a keratometer, intraoperative keratometer at the end of my surgery if I'm doing an SICS, and I try to titrate my astigmatism that way. So that's something that I do for keratoplasties very frequently, and I am able to keep my keratoplasty astigmatism within a reasonable amount, and it becomes easier with SICS when you do that. So you can put a suture if you want, if you feel that there is astigmatism. I'm not stuck on keeping it sutureless always. If required and for astigmatism purpose, I do sometimes put sutures.
Yeah, the other question is, before I go on, one more question in SICS, I would want to ask one on phaco. If a person has the other expert panel, Dr. Virendra Agrawal, I would want you to answer this. If a 95-year-old patient comes with a very black cataract and 4.5 millimeter pupil, and he wants a trifocal, would you advise him against a trifocal? Would you do an SICS? Do you think it is justified not to put a trifocal with an SICS in these cases? Are my thoughts.
Yeah. Give me a difficult situation and you want me a simple answer. So the thing is, he is 95, he is brown black, and his pupil is the thing. The pupil is not an important issue for end result, but definitely during surgery, pupil will make difference. Because having the brown black cataract, 95-year-old, so my advice in these patients, though I do some phaco into this, because I'm not able to do SICS, but if SICS is required, I have my team who will do it. I'm not against putting trifocal or bifocal into these patients because they are usually pupilly independent at the end. If at all they require some cylinders or they require some of the power, they will be more comfortable being independent of the glasses for their work. So I think there is no against for the lens. And choice between the SICS and phaco will depend on the different people. I know Dr. MSR is very expert in doing SICS manually, so he'll be preferring it. But for me, the phaco will be the answer.
Dr. Titial, if a patient has planned a multifocal and a nucleus fragment is there, PCR has got created. So would you think of still putting a multifocal in the sulcus, a 3-piece, or would you go ahead and do a monofocal and explain to the patient later?
Your debate has shifted to a different direction, It was against the manual versus...
Yes.
No.
But I'll answer your question because it will again depend on the size of a PCR we have in that particular patient. And if I can do a scaffold in that patient, that will be best. I'll put the intraocular lens, which may be trifocal. If it seems to be stable in the back, I'll put the lens and get the nucleus over the lens and do a phaco of that piece. But yes, if the PCR is too big and there's a lot of vitreous has come up, then we won't have a possibility of putting this lens in the bag, which is the requirement for a trifocal lens. You can't put on the sulcus. It has to be a monofocal multi-piece foldable lens in the sulcus in those cases. And most importantly, it will be the counseling of a patient after the surgery and the relatives to tell them that this was a situation and we had to do that. And that is, I think, the critical point rather than a multifocal or a monofocal at that stage of a large PCR.
Dr. Ramurthy, would you have anything to differ?
Time's up.
Yeah, I know. Yes.
I think this will work very well in MSR's case, but a couple of points that he made about phaco incisions, I would like to differ. I think all of us have shifted on to 2.4 millimeter incision with the modern machine. I'm not talking the absolutely high-end machines. There is very little heat generator. There is very little of wound distortion. So I do believe that the amount of astigmatism that's created by these incisions is also extremely small. Of course, horses for courses, I think you are an expert in MICS, and as Mohan Rajan said, most of us are comfortable with the phaco. I think we personally believe MICS definitely has a role in the Indian scenario. When it comes to premium IOLs, maybe phaco will score over it.
And Dr. Mohan, which would be the premium IOL case, which is a common cause for dissatisfaction not to put a multifocal IOL in your practice? Would be the last question before we go to our next set.
No, I didn't get your question, Chitra.
Which premium IOL, you in your practice, when is the time when you think there is situations when there is dissatisfaction, when you would not suggest a multifocal IOL in those patients?
No, I think the premium IOLs, you have to be very careful, especially when you're using multifocal lenses. Yeah, especially when the angle alpha is a little more than 0.5. My cutoff is about 0.8, 0.9. So you have to look at this. I do an eye trace for all these patients and make sure that the posterior segment is quite fine, and do OCT routinely for all these patients. So in a 95-year-old, you are talking about 95-year-old, you always look at the cornea. Please look at the cornea. If the cornea is not sick, go ahead with the phaco. Why not? Expand the pupil. You can do a phaco, even a brown black cataract without any problem at all, and put a multifocal lens. Yeah.
Dr. Chitra.
Yes.
We had an expansion of MSR, no? I have an expansion for Rajan.
Yes.
Rajan is an eye surgeon, so add an eye, not EYE, just eye. It becomes Rajani. We are all the Rajani fans here.
Yeah. So I think
is MICS Rajan.
Yeah, Dr. Ragini wants to add something. We could hear from her.
Respected Padma Shri, Dr. Tityal sir, Dr. Chitra, respected teachers and friends. So, of course, Dr. Ravindra and Dr. Rajan sir, both are my teachers. One thing I would like to say is that because we are doing a large number of SICS, there is a small amount of astigmatism, even if it is small, which always remains associated with SICS. You cannot get away with it. So I think that SICS has its role in the society, a very, very important one. Premium IOLs are here to stay, but they are both mutually exclusive. So when you are deciding to do an SICS, I would go with a monofocal IOL. And when I decide that this patient is there for premium IOL, then I would do a phacoemulsification, and all the counseling that gets done has to be done before the surgery. And all patients of premium IOLs, you cannot guarantee 100% that there will not be any PC tear. So you have to prepare all these patients for on-the-table change of
plan
IOL also. So these are the points I would like.
Wonderful. Wonderfully summed up, Dr. Agni, as expected from